We'll see whether all the new subscribers from TikTok have blown Substack's system. Okay, it looks like we're live on this live video chat thing. Hello to you all, I'm Bernard Hickey from the Kaka, and I'm joined this evening by Dr Gary Payinda, an emergency doctor from Northland, who has a fantastic Substack, which we'll refer to in the notes that go out with this. Great to have you on, Gary. We've had you on the Hoon before, but today is a good day. You've just put out an excellent post on the health system and how it hasn't really kept up with population growth, which is topical because today we have a new health minister. Shane Reti's been replaced by Simeon Brown, and so the government has presented this as, you know, a chance for something new to happen, for things to get better. But it strikes me that the budgets haven't been changed, and sure, the minister might be different, but we may not get a different result. So what can you tell us generally about how the health system is coping with its current funding levels and with that population growth over recent years?
Well, population growth over recent years, I'll start with that. Every year in recent years, New Zealand has grown by something like 93,000 additional residents a year, most of that inwards migration. And that's 93,000 this year, about the same last year, the one before that similarly. It's 1 million people over 20 years, which is when I moved here myself. And in that time, we should have had about 8 new hospitals built, and we've had none. We should have invested in schools, infrastructure, wastewater treatment, public housing, and of course, we barely are keeping up with where we should have been a decade ago. And health is no exception to that. You know, we talked about needing, for example, an IT restructuring because our system was so archaic. Our computers don't talk to each other. If you come to me as a patient, you might as well be visiting from Venezuela because I cannot access your medical information. The systems don't talk to each other. If you just live in town, the GP's system doesn't talk to ours. So the plan for years was to refurbish it. And they came up with this new idea to do that, allocated money for it. That program was underway. It's been stopped by this government. And you just think if we are making own goals like that, how can we ever get ahead?
Yeah, I wonder about this idea that somehow we can squeeze more services out of the same amount of money. This has been the theory now for a good decade in health, that yes, the amount that's being spent is increasing, but it's not increasing as fast as the need or the population growth. But somehow there is fat in the system that can be squeezed out and we can have more with the same amount. And it's interesting in the comments from Simeon Brown this morning on radio, he constantly made this point that the government had put $16 billion more into the health budget in the next 3 to 4 year budget period. But can you give us a sense of how that trying to do more with the same affects services on the ground in hospitals?
Well, I can tell you that emergency departments have seen their numbers increase by 18,000 nationally. That was reported last quarter. That is seeing more patients with less because we know that the government has cut about 3,000 roles in healthcare. They insist on this fiction that it's back office, but there's no such thing, right? These are the people. The back office are the ones who keep the departments running, right? Who get medical records, who prevent you from having hacking emergencies like Waikato had. And yet we've cut 24% of the public health budget, 47% of the data and IT roles. It's wild. It's ridiculous to think that at the very time we need it most, we're getting resourced less. And they'll often these politicians will say a cagey thing. They'll say, "Oh, it's the most money ever." But if you control for population growth, it's not. And if you control for inflation, it's not. So, of course, it's going to be the most money ever because New Zealand's population is the largest it's ever been by 93,000 this year. And I don't say we, government has done nothing about trying to keep up with demand, let alone fixing historical inadequacies. They instead put forth this line that we're overstaffed. We overhired nurses. Now, any nurse can tell you we are thousands of nurses short in the public health system. And yet, the rhetoric from these people, and I mean, whether it's Simeon or Levy or Luxon or Reti, these are all just talking faces. They're just on a mission to defund and destabilize the public healthcare system and use that money, that savings, to benefit, for example, landlords to the tune of 3 billion. So if you're a first home buyer, you get nothing. But if you're a 50th home buyer, you get your mortgage interest subsidized by taxpayers. So there's a little bit of crazy going on right now in the healthcare arena where people are letting them say these things that are just patently false. We know that healthcare funding has dropped by about 5% from the sort of last year to this year, if you account for inflation and population growth, which of course any normal person would do. And yet they're speaking in this rhetoric of things are okay and it's just back office cuts and highest staffing ever. And it's just a fiction. It's like a fictional world they're operating in. It's fascinating, really.
Yeah, I wonder too, not only have you got population growth, and you've got the natural inflation that comes from more medical devices, more ways to cure things, more drugs able to cure things, but also, particularly in the last 3 or 4 years, an increase in the number of people with mental health issues, an increase in obesity rates, in diabetes, and the like. So the actual demand coming from the population is more than just the population growth or the slightly higher inflation rates of healthcare. It's actually an increase in sickness as well.
And the aging population, right? There's the gray tsunami of baby boomers who've aged, who now need aged care, residential care, and hospital services. And in we've known about the tsunami for 20 years, and we've done literally, and we successive governments have avoided going there, have just ignored it. But what's a bit different is we've always had, John Key and the Labor guy, all of these governments were kind of choosing to ignore it. But this government is quite brash and bold because they're willing to say, "Oh, this problem that you see, it's not real. No, it's not real." And for anyone in healthcare, or I should say now for the general public who are patients, they look at the state of primary care. They know they can't get a GP appointment. They know that there are whole areas of New Zealand that will not have a single available GP. They're closed, the books are closed. And people realize that the things are not what they're being told. And I think we'd have a lot more respect for government if they just fronted up and just were honest and said, this is our long-term plan for addressing growth in New Zealand, because we have to. Otherwise, things are going to get worse and worse, and waiting lists will continue to blow out. Um, and we have to also admit that this isn't a lack of money. It's not that there's not money in New Zealand. 19 million, sorry, billion with a B, $19 billion was spent to give mainly the wealthier people in society tax benefits and tax breaks. 3 billion of that was for landlords to get the ability to have taxpayers fund their mortgage interest on their second, third, or 50th home. And, there needs to be someone from the other side, or even from within national, let's say, saying we have to look after our own people. And for 3 billion that we gave landlords, we could have provided every New Zealander with comprehensive dental insurance, free dental insurance. So when I mean, billion sounds like nothing to me. I just slipped up a second ago and didn't even know the difference. But billion is a vast amount of money for a small country, and you could get free dental and cover our staffing shortages, get rid of these waiting lists for the amount of money that we have given to the top tiny echelon of property owners. And of course, when I say this, people will say, well, there are some mom and pop landlords that are doing it hard, that have a tiny unit, fine, we can exempt those. We can protect those people. But the ones who don't need protection and who don't need taxpayer money are people with 200 units. Like, and yet we're subsidizing their mortgage interest. It's absolutely insane. And I would just say to listeners, readers, whatever you call it, don't let them tell you there's no money. There is money. It has been promised to people more important than you, people who are higher priority than my patients, my people in Northland. It's been promised to the wealthy.
You've mentioned in a couple of your blog posts about the risks of outsourcing of healthcare that's currently provided by hospitals, the increasing talk about using public-private partnerships, outsourcing surgeries, elective surgeries to more and more of those to private hospitals. What are the risks there, and what's the research overseas telling us about the quality of the care and the cost of it in the long run?
So this week, I'm going to put out a little summary article on some academic research that came out recently that showed actually a decrease in quality of care and survival, increased hospitalization rates, and higher death rates in systems that go down the path of private equity and private ownership. And they demonstrated an intermediate result for nonprofits and the best result for public hospitals. And what's fascinating is people labor under this delusion that private care is better. And if you're very wealthy, of course you get nice marble floors and things. You know, it's a nice room you'll be in, good food, but outcomes are actually worse. And we have to also remember that the private sector has to do all of that while extracting profit to give to someone. And that might be 10%, it might be 30%, like some of the health insurance companies in the States. When you're carving out 20 cents out of every dollar to give to a corporate shareholder or a corporate owner, you have to make compromises. And what you do is you understaff. You work people very hard, you cut down their numbers, and you cut corners. You avoid doing the expensive procedures. You avoid taking care of complex patients. I mean, there's a formula to this, and I trained in the US. So I very well understand how private healthcare works. You force the public system to take care of all of the super hard cases and the ones that are complex, people with multi-organ problems and problems of addiction or obesity or any of that. And you keep the clean and simple stuff like orthopedic surgeons scoping knees, right? They can crank those out all day. You keep that in private and you just turn it into a money mill, churning it out. And as soon as something goes wrong with one of those knees or one of those cataract cases, where do you think they go, Bernard? They go on the first ambulance possible. They get shipped out to the public hospital for us to take care of them.
And
So
in a way,
it's a rort. It's a
yeah,
rort. That's all I'll say on it.
yeah, no, and in a way, it's a public subsidy for private users of health insurance. And it seems to me that when the government says it wants to squeeze more for the same amount, it needs to look at the cost of New Zealand's healthcare as a share of GDP compared to those countries with much higher privately provided healthcare. So you're looking at the total cost of healthcare being twice or three times as much in those countries like the United States or Australia than our publicly funded healthcare system, which seems to me to blow a hole in this idea that there is lots of efficiencies to be gained. I'd like to thank you very
Can I
much. Sure.
just jump in with one last point?
Yep.
What'll be interesting is if we look at who actually benefits from private care. If it's not the patients and it's not the society, who benefits? Lester Levy had a hand in something like 20 or 30 private healthcare businesses. Right up until the minute he started this work, he was like divesting himself as quickly as he could to not be sort of caught red handed with conflicts of interest. But these folks have private ownership stakes, or until very recently had them, Shane Reti and others, in private healthcare. What does that mean? Well, these are the same people who've been put in charge of the public system. of course their recommendation is going to be towards privatization. Run it down. So my comment has always been they're striving to defund public services, destabilize them, and then privatize them. And I firmly believe that we are 2/3 of the way through that process now. So there are some big winners in this. It's just not you and me, and it's certainly not my patients.
Thank you very much. Dr. Gary Payinda, who puts out a fantastic Substack there on the first day of Simeon Brown's new role as Health Minister replacing Shane Reti. Gary, thank you very much.
Thank you, Bernard. Talk soon. Bye.